We move on to the next presentation, which is by Dr. Anu Bihari. She is a professor of surgical gastroenterology and my former colleague for more than 3 decades at SGPGIMS. And the presentation will be chaired by Dr. Paleswan Lakhi Joshi from Kathmandu, Nepal. Anu, are you there? Anu, aap muted ho. Please unmute yourself.
Thank you, sir. Good evening, everyone. So after the excellent presentation by Professor Sadiq Sikora, it is my honor to invite Professor Anu Bihari. She is the consultant and professor of surgical gastroenterology at SGPGI Lucknow. And I would like to invite her for her talk on troubleshooting in cholecystectomy, bile leak, and bleeding. Dr. Anu.
Anu, are you able to share your screen, or you want me to share your presentation?
Only the host can do. So will you please share it? Are you able to hear?
I'll do it. Is it seen?
Yes, sir. Am I audible?
Yes, please. Yeah, please start.
Very good evening. Thank you very much, Dr. Kapoor, Dr. Sikora, for giving me this opportunity to participate in this very needed masterclass on safe cholecystectomy, an issue that is very close to my heart also. And if we see today, cholecystectomy should be done with almost no mortality, very little morbidity. And the expectation is that this will be an operation admitted on, say, the evening of the operation, will be operated, will be discharged the next day. But the scenario can I go back to the previous slide?
Sorry, I'm sorry.
Yes. But as soon as bile duct injury or vascular injury enter the equation, suddenly the situation doesn't remain so simple at all. The mortality, the cost, hospital stay, number of interventions, everything increases exponentially, and suddenly mortality is very much a possibility. And this situation is very raw for me. Last night, the department lost a 34-year-old mother of 2 following a laparoscopic cholecystectomy injury, was referred very late with sepsis and multi-organ failure. So may I please go back to the previous slide? I'm sorry about this. Sir, may I please go back to the second slide?
This one or the next? This one?
Hello?
Yeah. This one or next?
Yes, sir, this one. So I know that the topic that has been given to me is like troubleshooting. So meaning what to do when trouble strikes. But considering the potentially devastating consequences of major vascular biliary or combined biliovascular injuries, I think the surgeon's intent and efforts should always be geared toward, I think all the speakers who have spoken yesterday and today have emphasized this culture of safe cholecystectomy, and I feel that understanding and rigorously following the basic tenets of safe cholecystectomy are fundamental and essential to minimize the occurrence of major vascular or bile duct injury. So basically, what we need to know is the relevant anatomy of the region, including all the variations in biliovascular anatomy and their surgical significance. We also need to understand the surgical significance of alterations in anatomy, which may be brought about by altered pathology, as in acute cholecystitis, as you just saw in the presentation by Dr. Sikora, long-standing gallstone disease, chronic cholecystitis, Miruti syndrome, presence of associated diseases like cirrhosis, portal hypertension, and EHPV, as previous speakers have mentioned, Previous surgical or non-surgical procedures, say upper cutaneous cholecystectomy, upper abdominal surgery, previous intra-abdominal conditions like, say, pancreatitis, and the management options in the face of altered anatomy, physiology, and pathology. So, as Dr. Sikora's presentation on difficult cholecystectomy, so may I move the slide? Next slide. Difficult cholecystectomy will translate into an increased risk of intraoperative bleeding and bile injury. So we should prepare well. And how do we do that? By appropriate patient selection and preoperative optimization, having even a better assistance than you would usually, including help from a more experienced colleague, intraoperative biliary imaging, well-maintained instruments and energy sources, and topical hemostatic agents. But most importantly, I think every surgeon needs to match one's experience to the difficulty of surgery. And this is a graded progression. I don't think a newly passed out MS general surgery resident can do the kind of cholecystectomy which Dr. Sikora just did. And that is not a problem. The experience is going to increase gradually. The surgeon should know which patient to choose. Always keep safe bailout techniques in mind, including retracting the decision to continue with cholecystectomy or give up totally. Next slide, please. Intraoperative bleeding, and right at the beginning, I'll say that today I'm not dealing with trocar-induced or access-induced injuries to the major vessels, and I'm restricting myself to bleeding during the arterial cholecystectomy, which may vary. It's a huge spectrum from minor, easily managed to catastrophic bleeding, leading to hemodynamic instability during surgery and liver ischemia requiring early or late hepatectomy later part of the post-operative procedure, post-operative period. Next slide, please. May I have the next slide? Sources of bleeding during cholecystectomy. Now, they can vary from, like, even before you get to the gallbladder, there may be pericholocystic adhesions, omentum being very common. So, omental vessels may be there. The trocar sites may be the source of bleeding. The liver, especially when cirrhotic, fatty, even adhesions which are so simple, and in a normal liver, may just lead to this small abrasion of the liver surface, can lead to bleeding. And usually that is because of inappropriate traction or incorrect plane and can be taken care of by with sharp dissection incorrectly. The liver, especially when it is cirrhotic and fatty, may also get injured from ports and instruments and forceful GB retraction. Next, please. Oh, the most common source of intraoperative bleeding during cholecystectomy is the GB bed. Now, from the bed, the bleeding may be in the form of diffuse ooze, as may be seen in acute inflammation and when cholecystectomy is done for acute cholecystectomy, or because of the collateralization, as may be there in cirrhosis and portal hypertension. Bleeding from the GB bed may also be because of injury to terminal tributaries of middle hepatic vein. In about 10% of people, these can be very close and may be very large, as was shown by Dr. Brar and also Dr. Sadik. Also, it is very important to remember that injury to the right portal pedicle is possible if in long-standing chronic inflammation, there is thickening and foreshortening of the cystic plate. So as we come close, and especially if it is a small contracted gallbladder, we may very quickly reach the right portal pedicle, and chances of what Strasberg has called devastating, like ambulovascular injuries, can happen. More common sources of bleeding can be, next slide please, the cystic artery. It may be the normal cystic artery during dissection or one of its branches, or more likely an aberrant cystic artery, which is aberrant in origin, and therefore the course, location, and number may be variable. And very importantly, a very short cystic artery. The right hepatic artery, which is the most commonly injured major vascular structure in cholecystectomy, is more likely to get injured if it is anteriorly placed to the common hepatic duct, in contrast to its normal, usual posterior position, or when it has what is called as a caterpillar hump. The thing is that whenever there is a caterpillar hump, usually it is associated with a very short cystic artery. Luckily, and the portal vein branches is much less common, but can be devastating, as can be combined arterial and venous disease. And in fact, I think portal vein injuries, many of them are actually underreported because many of these patients who have torrential hemorrhage may not even reach the center from which reports of injuries come. Now, what happens when you encounter bleeding during cholecystectomy? What you should absolutely not do is panic and start. If it is a laparoscopic cholecystectomy, don't start cauterizing or clipping, suturing. It is going to be ineffective first, and most importantly, it can lead to further injury. In fact, it can lead to injury to the bile duct, or may exacerbate the already present vascular injury. What you should do is pause. Just put if it is laparoscopic, you can still put a pack and gauze open. Again, you can put pack and gauze. Press and wait. Be patient. While you are pressing, it will give you time. You can call for help. You can reassess your situation. And if you're doing it laparoscopically, you can think whether you need an extra port for suction, for resistance, and also think whether you require conversion. Next slide, please. Now, when you are pausing, like again, one of the tenets of safe cholecystectomy to pause. Now, this is the time when you have bleeding. What you need to assess is, what is the site of the bleeding? What is the nature, like a arterial spurter or like venous ooze? Extent, is it just a small trickle or it's large amounts are coming? And this will allow you to assess whether you need help from a more experienced colleague, whether you need extra ports, whether you need extra instruments or energy sources. And while you are assessing, just keep the pressure there and don't remove the gauze every 2 minutes to see whether the bleeding has stopped. Also, very importantly, inform the anesthetist that there is bleeding. Normally, during cholecystectomy, blood will not be arranged unless you have seen that preoperatively you have detected that the patient has portal appendage surgery and you want to be better prepared and you already have arranged blood. But inform the anesthetist so that resuscitation and arrangement of blood products can be made. Put another port for suction if you're not able to do with the number of ports that you have. Keep the field clear as much as possible so that the bleeding will come down to a level that you can assess whether you will be able to use cautery, clip, suture, or a topical hemostat as may be required. Also, assess the need for conversion to open. Now, coming to the gallbladder bed, which is the most common site of bleeding during cholecystectomy, as has been stressed by so many others, and I would like to reiterate, a difficult gallbladder bed should not be a surprise. And in difficult cases, preemptively we can choose to leave the posterior wall attached to the liver and ablate the mucosa. Remember that the right portal pedicle can be really close and in danger of injury in patients with small contracted gallbladders who are likely to have foreshortened and thick cystic plates. Opt for a bailout technique like subpleural cholecystectomy or even a cholecystostomy or even just putting a drain and cut out. If the bleeding from the gallbladder bed is a diffuse ooze, as is likely to happen, say, for example, you have operated for a patient with cholecystitis, initially put pressure with gauze, use electrocautery, like a spray mode we can use, depending upon how much is the bleeding. Local hemostatic agents are good for this kind of bleed, and oxidized regenerated cellulose, which is Surgicel. Many studies have shown that it's quite helpful in many such situations. You can put it there, put your gauze piece, wait in, and diffusers should be taken care of. People have used gel foam, fibrin glue, even omental flaps and falciform flaps to assist. Don't use electrocautery indiscriminately because there is the likelihood of injury to cervical ducts and also terminal tributaries of middle hepatic veins. Omental arteries Usually after you have had, after with suction, pressure, you have had a clear field, then you can use cautery, one of the energy sources, or suture or ligate if you're doing an open procedure. The cystic artery and branches also can be reclipped. You can use one of the energy sources, or you can use a ligature or suture depending upon your condition. The right hepatic artery is most often, actually, at times of bleeding, gets clipped and goes unnoticed. If it is noticed that the right hepatic artery has been injured and you have seen it intraoperatively, assess if it is possible for you to manage it laparoscopically, otherwise convert and suture or repair. If expertise for repair is unavailable, it is better to secure it safely and tie it off, control the bleeding, and monitor closely for evidence of liver ischemia. It may happen in not more than 10% of patients, and there are several other factors which may be if there is no associated bile duct injury, if there is no associated portal vein injury, the patient may escape major liver ischemia. When should you start getting worried? If there is ongoing substantial bleeding with all that you have done, it is likely that there is, especially from the gallbladder bed, that there has been a venous injury or a combined venous and arterial injury. Start reassessing your options depending upon your experience and the infrastructure that is available to you. If you feel that by converting, you can suture control, you have the ability, you can do a Pringle maneuver, take sutures over the vein, you can do it, but continue careful monitoring for bleeding and liver ischemia. If you can't, convert back and refer. Continue resuscitation, stabilize as much as possible, document in detail before referral. If possible, talk to the people in the center that you're referring, explain, get their advice as to how you should manage while you are shifting the patient, and then shift the patient.
Anu, another 2-3 minutes.
At what stage of dissection? You may discover bile leak after having achieved a clear CVS and removing the GB, bile leak from the bed. You may notice that a cystic duct a clip has slipped, say because of inappropriate size, too thick, too wide, while dissecting the cystic duct artery. Sometimes, after having clipped and divided what you thought to be the cystic duct and then dividing some more tissue in the GB bed to separate it completely, what is the classical injury? The bile is from the divided CHT. Very scaringly, very frighteningly, sometimes after prolonged attempts to control bleeding with the electrocautery, bile is seen leaking in the field. I would say, unless it is clearly from the gallbladder, like the greenish yellow bile with some stones, take it as ductal injury. Now, once there is the suspicion of injury, again, we need to pause because we need to assess three things. The injury, meaning identification of the duct, the extent, the level, associated vascular injury. We also need to assess the expertise that is there of intraoperative cholangiogram, laparoscopic or open management of the bile duct injury, and the infrastructure, whether there is a support for the laparoscopic or open management, endoscopic interventions or radiological interventions. Now, should we convert just because we think that we have injured? Mere conversion may not improve exposure or clarify anatomy because even a difficult cholecystectomy will remain difficult at open also. And experience with open cholecystectomy, this may be even more so. And the same care has to be taken after conversion to ensure that the injury is not further compounded. If proper assessment can be done laparoscopically, conversion is not a must. If the surgeon's assessment is that because of lack of experience or infrastructure, the surgeon is going to refer, then just put a large subhepatic drain laparoscopically and refer. Or if the surgeon clearly recognizes that the experience and expertise is available and can be managed laparoscopically, then also there is no need to convert. Now, if the bile leak is from the bed, I think this was discussed yesterday. If it is less than 3 millimeter, we can clip or suture. If it is more than 3 millimeter, it is likely that it may be draining a large sector or segment. So all subvesical ducts are not the same. And that is why the injunction to do a bilioenteric anastomosis if it is a larger duct. A cystic duct slip clip can be managed by reclipping, endoloop, or suture. Always put a subhepatic drain. If there has been a complete transaction, especially with tissue loss and high injuries, a RUIJ is advised, but with the caveat that no associated vascular injury is there, in which case even experienced surgeons may choose a delayed repair. If there is partial or complete loss, there is space for end-to-end anastomosis with fine monofilaments, which is, people always say T-tube, but I always wonder when a common, like a normal size CBD is injured and like you are stitching it end-to-end, you want to bring out T-tube from another hole in the CBD. I mean, that is, in my mind, compounding the injury. We can do it over a stent also, or simple suture with a subhepatic drain. And we can elect for post-op endoscopic stenting, depending upon what is the extent. If expertise and infrastructure is not available, put a large subhepatic drain, document the intraoperative findings, whatever you found, and the procedure, inform and counsel the patient and family, and refer to a center where expertise and infrastructure are available. So if I have to say what messages, obsessively follow the basic tenets of safe cholecystectomy. Do not let the apparent simplicity of the procedure lull you into a false sense of security. Learn to anticipate and prepare well for difficult cholecystectomy. Tailor and match the patient selection to experience. Do ask for help in a difficult situation. Honestly assess experience to deal with major bleeding by leak and act accordingly. Choosing referral is not a failure. It may be the wisest and safest decision that you have ever taken. Do refer after resuscitation, stabilization, drain placement, and packing. As Dr. Kapoor always used to say, to injure is human, to refer is divine. Thank you.
Thank you.
Thank you, Dr. Anu,
Yeah,
for thank you, Dr. Anu, for your nice elaboration on troubleshooting in cholecystectomy. And you rightly said that the complications like bleeding and bile leak occurs because of 3Ds, that is dangerous disease, dangerous anatomy, and dangerous surgery. And you've very nicely elaborated the various techniques to manage bile leak and bleeding. And are there any questions from the other faculties? I don't see any questions in the chat.
Take the questions and comments from the chat box. If you open the chat, you want me to read it?
So I don't see any particular questions for Dr. Anu. So there's one question by Heathen Win, where the question is, can you please share, if any, experience the injury to accessory right hepatic artery during lap chole?
Actually, I have not experienced myself personally. I don't know if Dr. Sikora or Dr. Kapoor would like to.
Yeah, but the management would be same as of a normally placed right hepatic artery. So I don't think it would be any different. Only thing is that if it is really an accessory, not a replaced, then you have a low threshold to just clip it to control the bleeding, because you know that the normal artery is also there. In fact, I always tell a general surgical audience that if you have a right hepatic artery injury and you are finding it difficult to control, in a normal liver, which is not cirrhotic, ligating or clipping the right hepatic artery most probably would not do much harm, except some elevation of enzymes in the post-operative period. So if it comes to that, it is better to save the life of the patient rather than try to continue to save the right hepatic artery.
And so pre-operatively, like...
Sorry, go ahead, Anumam.
Can I make one comment? KJ, is it
Yes,
okay?
sir.
Can I make a comment?
Yeah, sir, I'll take it after you. Yeah, sure, go ahead, sir.
So, I mean, Anu, you did a great job in telling how to control bleeding and what to do. I want to reiterate that all bleeding stops with pressure, especially those during a cholecystectomy. And pressure is the treatment, not cautery, not clip. And that has to be emphasized, that at least you would get enough time to assess, reassess, call for help, prepare, and then you would see what is the cause of bleeding. So I think pressure part is very, very important. So that you have emphasized, and I think that has to be the most important message which goes from troubleshooting, which we can put.
So I'm sorry, I did a mistake. Kamaljeet, yes.
Yeah, good evening, Dr. Anu. Great to listen to your lecture. All practical points valid and well taken. I have a substantial experience of roaming a repair of CBD injuries in the field. In fact, to the extent that I have a fine set in my car, always autoclaved with the number 10 T-tube. But once it so happened, and a couple of times it's happened, that the T-tube number 10 is usually not available easily in the market. Only a GI surgeon who's taking interest in CBD, salvage would ask for it. It's difficult to procure it. So I've multiple times what I've done is, and in centers where there's not enough, lighting or not enough infrastructure to do a RYHJ, in those centers, I mean, as a bailout procedure, you may call it, or as whatever, end-to-end CBD repair is definitely an option. But I always use a T-tube once, so many times when the T-tube is not available. Just as a temporary measure, what I do is take a 6-7 number infant feeding tube, cut it, and use it as a stent, because obviously stent is also not available. The tube will pass off in a couple of days, 3-4, but it will do its job of allowing a good anastomosis or end-to-end anastomosis. It works well in cases in which I've tried.
My suggestion, KJ, since you carry fine instruments and all, carry stents also with you.
Yeah, I know, sir.
Avoid T-tube.
Yes. Totally taken.
Can I add to one more point? If you are
Just one more minute,
I think
because we have 2 more presentations.
No, sir, then it's okay. I just wanted to add that you should have a magnification and use at least PDS at 6.0, not less than that, because our duct is very small. So if you are doing end-to-end, we have to be very careful about selection of the suture material as well as magnification.
Totally agree.
So I think I did a miscalculation. Actually, 3 presentations were supposed to be 20 minutes each, but I gave 30 minutes to all the presentations. So Sadiq, what we'll do, we'll skip the last one, the medico-legal aspects. I'll post
No. Mine is not very long. So you please also participate. I'll finish in about 8 minutes
Okay.
or so.
Okay, so